All right, so thanks everybody. Welcome to our first webinar of 2014, and thanks to everyone for attending. Please keep in mind if you do have a noisy background, we'd appreciate you muting yourself by hitting that little green microphone. That way we'll keep nice, clear, and clean recording for everybody. My name is Brian Miller. I'm the regional representative for Anabolic Laboratories in Delaware, Maryland, Virginia, and West Virginia. Also on the line is Bob Rosenberg, the regional representative for Anabolic Laboratories in Pennsylvania and New Jersey. Rounding out our team is Dr. David Seaman, professor of clinical sciences at the National University of Health Sciences in Florida, and author of the book Clinical Nutrition for Pain, Inflammation, and Tissue Healing. Also author of many other articles on nutrition, inflammation, neurology, and so on. So our goals with the presentation are to overview Anabolic Labs' Nutra-Disc formula, have Dr. David Seaman discuss discogenic pain and disc injury, present how Nutra-Disc is an ideal nutritional formula to incorporate with manual care, modalities, posture, and rehabilitation, and discuss dosing recommendations, patient pricing, and the available patient education materials. I'd like to ask everyone to hold any questions until the end so we can move through the material in a reasonable amount of time. We'll be happy to cycle back through the presentation to the point of your question. So let's go ahead and begin with an overview of the Nutra-Disc formula. And what we have here is basically just a general rundown. As you can see, Nutra-Disc is a blend of ingredients. Probably the best way to take a look and analyze this formula would be into three parts. First part being the glucosamine and chondroitin component of it, which is basically your disc nutrition component. At this point in time, the glucosamine and chondroitin has been well established in regards to its benefits and ability to contribute to joint health. What I've put up is a backgrounder from Council for Responsible Nutrition to basically just provide a very brief overview of the benefits of glucosamine and chondroitin. As you can see, their listing in their backgrounder includes reduced joint space narrowing, improved joint comfort, improved mobility, production of new cartilage, and for all intents and purposes, no adverse effects reported. The second component of Nutra-Disc is the Meriva bioavailable curcumin. Curcumin is the extract of turmeric, which gives turmeric its color. What Meriva is a patented proprietary ingredient which includes a phytosome technology. The bottom line is a lot of turmeric gets used up in the digestive tract. What the company Andina has done with some technology in the ingredient is to increase its absorption rate 29-fold versus the standard 95% turmeric extract. So we just have a more concise derivative of turmeric and improve absorption rates. Curcumin is the yellow pigment, as I mentioned, that gives turmeric its coloring. And as you'll see, its background and research by medical literature has proven it to be quite an effective nutritional product when we're talking about things like reducing inflammation. What the Meriva version of turmeric brings us is just a much more improved version of that, and as I mentioned, 29-fold versus the standard 95% turmeric. So what we have is a really effective gold standard version of the botanical anti-inflammatory agent. The third component of Nutra-Disc brings us down to its proteolytic enzyme blend, which we have labeled as Z-Pro enzyme blend. What Z-Pro enzyme blend is Anabolic Labs' custom blends of enzymes. So a variety of proteases, proteolytic enzymes, are effective at a variety of pH levels in the gut. This assures better activity, especially early on in the GI tract, so we gain more of a systemic approach to the utilization. Also, each type of protease has been shown to interact differently in regards to its anti-inflammatory benefits at different points in the cascade. So once again, the combination offers a more complete, well-rounded collection of proteolytic enzymes. The last proteolytic enzyme noted on the list there is Serazymes, which is another proprietary ingredient, and this is basically an exclusive enzyme system, and it's designed to be an alternative to serratiopeptase, which is basically a naturally occurring ingredient that is both fibrinolytic and also anti-inflammatory in its actions. So the Serazymes are a derivative of basically what you see on the screen as described as mushroom fungi. Once again, Serazymes themselves are a blend of these proteolytic enzymes within there. So we're just getting more broad spectrum and more activity in the digestive tract and systemically. So this provides a broader range and just a better quality aspect in regards to going after our goal here. In essence, what we have, if you take a look at the three components combined, we've got disc nutrition and glucosamine and chondroitin. We've got a very high-performing curcumin in the Mariva brand. We've got a wide range of the proteases under the Z-Pro blend and the Serazymes. When you combine all three up together and look at what they provide in addition to their individual activity, they all basically
starting to snow at Julie's.
They all become basically anti-inflammatory agents as a grouping themselves. So at this point in time, I'd like to invite Dr. Seaman to come on the line and discuss some of the clinical aspects of the ingredients and thus the formula as well.
So am I coming in okay?
Yeah, a little more volume would be good, but
I can just talk louder. I can talk louder. Is that good?
Talk louder.
Yeah, and people should turn off the background music because I can hear myself a little bit. I mean, I can hear myself, so if you turn off, if you go mute, that way I won't be listening to myself in the background.
I'm going to go ahead and mute everybody for you, Dave.
Perfect. First page. You unmuted then? I hear unmuted. I hear me. Okay. Assuming you guys can hear me, I guess you'll come back on if you don't. The first slide that you see in my component of the presentation is the disc piece that I wrote for the Nutra-Disc product, and it really wasn't designed as a as a piece for the product so much as it was written in the context of what actually happens in the disc herniation process. And as we go through this, in the chance that, I mean, probably a good chance actually that I haven't, some of you haven't seen this presentation before or haven't heard me before, I take a different description of disc herniation after I relearned it after I graduated from Cairo School. It turns out that for the most part, MD school, med school, PT school, DO school, DC school, we get a little bit of a backwards description of how disc herniation occurs. The next slide just puts in context the percentage of pains in the back, in the low back, and tissue sources. So you can see that the SI joint is going to be 20%, and then the facet joint 15 to 40% depending upon age. The primary driver of chronic low back pain is the disc itself, and that has nothing to do with herniation. I graduated really not getting primary disc pain, and even into the 80s when I first started chiropractic school in 82. There was still a debate, actually. I think Bogduck wrote one of his first papers back in between 80 and 85, where they were still getting over the debate about whether the disc itself was innervated. In 1934, Mixter and Barr, who were associated with Harvard, didn't realize that they were taking out a herniated nucleus. They thought it was a tumor between the vertebra, a tumor in the disc that didn't have growing cells, and then they brought it to the lab and they realized it was actually the nucleus that was herniating. So it's been kind of slow, and actually Harvard, they had slides of the tumors that was actually the nucleus, and they said it's a weird kind of cancer because there are no cells there. And that was when Mixter and Barr realized that it was actually the nucleus itself. So that was back in 34 or so, 34 to 50. So in 80, they still weren't really sure if the disc itself was innervated, and then finally we realized it was innervated, and the outer third is what is innervated. So the next slide gives us a quick cross-sectional, it's actually sagittal anatomy of the disc. You can see up top you have the end plate above and below the nucleus, and you can see the inner layers, the inner two-thirds of the annulus. The inner two-thirds of the annulus invests into the end plate, and the outer third invests into the vertebral body. And that outer third of vertebral body bone is called the ring apophysis. And those are very, very strong attachments into the vertebral body, and strong attachments into the end plate as well, except that the end plate is very, very weak. It is the weakest link within the disc complex. And it's literally impossible if you take that disc complex in front of us, there is absolutely no way to herniate that. If you had a brutal crushing blow, the vertebral bodies would fracture. Nothing would happen to the disc. Well, depending on how intense the fractures, but a compressive force sufficient enough to fracture the vertebral bodies would not damage the nucleus initially. So it's quite shocking, actually, how strong it is. So it's kind of important to understand what these guys are made of, and I didn't really get it, again, until I relearned it probably back in the early 2000s. So the annulus is dry weight. Now, if you look at the entire body, it's mostly water, so when you kind of dry it out and you look at the difference, you can see that the annulus is mostly collagen, not much proteoglycan, and the nucleus is mostly proteoglycan, a lot less collagen. And it is the proteoglycan that allows for the nucleus to suck up or imbibe the water, and then it allows for the nucleus to withstand compressive forces. The next slide just gives us a quick look at what the proteoglycan looks like. It's made up of keratin sulfate, chondroitin sulfate, hyaluronic acid. And so what we see there is a big proteoglycan aggregate, as it's called. And you see the chondroitin sulfate chains, you see keratin sulfate, and you can see hyaluronic acid. Well, the chondroitin sulfate is a component of Nutra-Disc, as is, you might not think it, but glucosamine is part of the backbone of hyaluronic acid. And glucosamine itself is converted into two sugar molecules further down the pathway that become chondroitin sulfate. And they're negatively charged. And the negative charge allows them to imbibe their water. So we get our nuclear hydration, as we call it. And so the next slide just gives us an idea as to what it looks like when you get a compressive force. The nucleus is the one that deals with it. And the nucleus then redistributes the compressive force to the vertebra above, below, so the end plate above, end plate below, and then circumferentially out to the annulus. Now in this particular scenario here where we have a perfect disc complex, The annular fibers bear very, very little load. The Z joints bear very, very little load. The load is being borne by the nucleus, the beautifully magnificent looking hydrated nucleus there. And the problem happens is when we end up with a damaging event. So if we have, and it's usually not one compressive injurious event. Someone might say that pain goes shooting down their leg and they actually herniate. But prior to that herniation event, they had a nucleus that was damaged for a long time. You can literally take a knife, a scalpel, after either of a pig's cervical spine, which is just like a human lumbar spine, slice right through the annulus out to the nucleus and compress away, and no nuclear material is going to move. So it's very, very difficult for there to be a herniating event suddenly from this scenario that we're looking at right now. There has to be a progressive process, and we're going to go through that in a couple seconds. So you have an injurious event that takes place, and if you think about it from the perspective of playing golf, a golf swing generates about roughly 8 times the body weight in compressive load. So there's this rotational moment that's taking place, and then we have this compressive load, and then what will happen is the end plate will become damaged. And it can be very, very subtle, and you may not even notice it, but what will happen is and what we can see in this particular image is that below the vertebral end plates, you've got vascular buds that go into the vertebral end plate. And those vascular buds are part of the way that the nucleus and the end plate gets its nourishment. And you also have innervation as well as vascularization of the outer third of the annulus. And so through osmosis, you get nutrients that way as well. Well, if there's damage to the end plate, which can take place very, very subtly or with a traumatic event, we set up a scenario whereby that beautiful nucleus starts to basically get digested. And it doesn't get digested as in it goes away. Its structure gets changed. Because what we're looking at there is a very cohesive looking nucleus. And this nucleus becomes, well, it loses its cohesiveness and becomes expressible. Again, if you were to take a needle or a teeny weeny, ice pick that's very, very small and puncture right through the annulus and get to the nucleus that was like this and pressed away, it couldn't move outwards because it's cohesive and not expressible. So what happens when we have an adequate injury event is that subtly but surely the end plate is damaged and the nucleus is compromised by the blood supply below. It'll be very, very subtle. But what will happen is this compromise of the end plate changes the delicate homeostatic environment of the nucleus, and it leads to the induction of metalloproteinases. And so metalloproteinases are the guys that get in there and start to degrade the nucleus. You can see this paper was published back in 2009, and you can see the title, Matrix Metalloproteinases Expression Levels Suggest Distinct Enzyme Roles During Disc Herniation and Degeneration. So when I learned disc degeneration and the herniation process, none of this was even in my mind in terms of terminology. So what I learned back when I was in school, and probably most of you, was collagenase or gelatinase. Stromolysin I learned back in probably 10 years ago when I looked into Robbins pathology and realized, wow, look at that. So stromolysin, what it does, stromolysin is really a proteoglycanase enzyme. They call it stromate. Tissue stroma, stromolysin. Lysin as in degrade or lyse or break apart. So you have collagen degrading enzymes and proteoglycan degrading enzymes. And so you think about it, well, the nucleus is mostly proteoglycan, but it's got 10-20% collagen. So what happens is the nucleus starts to become degraded and what happens is the collagen and proteoglycans lose their structure and they lose their ability to imbibe water. And what will happen at that point is you'll start to get a slight compression scenario potentially, or a slight loss of disc height. No pain ultimately. But what's taking place during that process, there may be some pain in the low back, there may be none at all. It's not consistent across the board. But for sure what happens is the collagenases and the stromolysins, again, the stromolysins are also proteoglycanases, what they do is they progressively degrade the nucleus. And the next slide gives us the paper from which I pulled these images. And if you want to actually go online, you can pull down this entire paper and pull these pictures off. The next slide shows the phases of the discogram. And one of the confusing ones initially when we look at is grade 0, because before there was grade 0, there was essentially grade nothing. So there was nothing grade. There was just a vertebra sitting there. So if you go to the next slide, we're going to go with that vertebra. This is our perfect vertebra. There she is, or he is, depending. So this is grade nothing. It's normal, no M plate damage, no MMP stands for metalloproteinase, matrix metalloproteinase, which means collagenase, and stromolysin, which is also synonymous with proteoglycan ACE that I just made up. So MMP means the connective tissue degrading enzymes. So normally speaking, they're not on. The matrix is perfect. The disc complex is beautiful. The nucleus bears weight properly and transfers the weight, as I showed you before. The annulus and the Z joint, they bear minimal weight at all. Only the outer third of the annulus is innervated. There's no damaging events taking place. If you look at the Z joints in this picture, you can see that rotation is massively limited in the lumbar spine. So the idea that you're going to have rotational problems and strain the angular fibers is literally impossible. You actually have to fracture the Z joints and then rotate to 10, 20 degrees, and then you get some damage of the angular fibers in rotation. But it doesn't happen in real life. You only have rotational moments that are created, but rotational moments are created along with massive compression, which is really the combination of the two movements ultimately. So we have an injurious event, and all of a sudden we go from no grade, what we see right here, we move to grade 0. So grade 0 looks just like the grade before, which was nothing. And the reason why is because initially, after the metalloproteinases are turned on, we have no changes in the architecture of the nucleus. What has happened, though, is that the M plates have initiated the degradation process. There's no annular invasion. What you're going to see as we go through the process, you're going to see how the herniation process is an inside-out process versus what I learned, and probably lots of you learned, that we through rotation and flexion, compression, whatever it is, we damage the annulus and delaminate the annulus, and there is a coalescence taking place of circumferential tears, and that leads to a radial fissure that moves towards the nucleus, and out comes the material. It's impossible. It just cannot work that way. And the next picture will show us exactly how it works. So if there's any pain at this point, and in the previous image, the pain could absolutely not be discogenic, because discogenic pain is pain that occurs when the nuclear material has migrated all the way out. So if, in fact, the annular tearing, circumferential tearing in the periphery was to coalesce and create a radial fissure, that would mean that we would see, we could not see this image on a discogram. This demonstrates, without a shadow of a doubt, Perry Mason would love this one. This is a perfect picture. It is an inside-out process. So after the metalloproteinases, the collagenases and stromolysins have degraded the nucleus, they kind of move. Now the nucleus has become more fluid, and you can have a slight bulge, and maybe not a big one. It's very, very variable. But now the nucleus has lost its cohesiveness, and so the metalloproteinases kind of move in the direction that they're pushed based upon the mechanics that we create. And as you know, most disc herniations are posterolateral because we flex and rotate. So the reason why disc herniations occur in the posterolateral zone, like you see here, is because we're flexing and rotating, and that just pushes the enzymes towards the inner layers of the annulus in that posterolateral area. And so the enzymes do what they do. They continue to degrade the new connective tissue that has not been degraded yet. So they degrade the inner third of the annulus. And at this point, the annulus starts to bear a little bit more load. The Z joints start to bear a little bit more load compared to grade 0. But any pain that exists would not be discogenic as is properly defined. That is when the nucleus reaches the outer third. So pain now is not discogenic. It could be muscular tightening. It could be some instability. It could be Z joint the chance that it's going to be outer annulus by itself is very, very rare. And the same holds true for a grade 2 discogram. So now you can see that the matrix metalloproteinases have bore a hole into the through the entire inner 2/3. Notice that this is absolutely not coming from circumferential tears coming together to create a fissure, a radial fissure that bores internally. It is the opposite. So again, you can have a bulge, slight, large. It's hard to really say. And there has been no correlations as far as I know. But now the annulus and the Z-joints must bear greater compressive burden. And at this point, the annulus, by bearing a greater compressive burden that it never had to bear before, because remember, when we looked at that beautiful disc complex initially, we saw that the nucleus was bearing all the weight and it distributed it out towards the annulus. Now, the annulus does bear some weight, but nothing compared to what's taking place now. So now is the likely time when you can get some delamination of the outer third, and perhaps part of the middle third of the annulus. And again, it would still be not likely discogenic at all, maybe teeny bit annular pain, maybe, no one knows for sure, most likely more Z-joint bearing the load. And then what happens after we have this bearing of load on the outer annulus, you may get some delamination, which shows up in the grade 3 discogram. And so the next one shows us the grade 3. And so now you can see that the why some people would think, and why it's normal for us to have been taught, not maybe not all of you, but I certainly was, and I know hundreds of other DCs were, why you might think that it's the circumferential tears externally that then move into the nucleus. Because when you look at a herniation in progress like this, well, that's what it looks like. But if we look at the previous discograms, we know that it is absolutely an inside-out process. So now that we have the outer annulus being bombarded with this very acidic material from, which is what the nucleus is, very, very acidic, very inflammatory. An acidic load is going to be, or acidic chemistry is very, very irritating to nociceptive fibers, and you have massive nociceptive innervation of the outer annulus. So now if pain exists, and sometimes it doesn't exist. It's very bizarre. It's not perfect. You can have disc that would look like this and have no pain. So, but if there is pain, this is called discogenic. And it's discogenic because the disc itself is now exciting the nociceptors. And there may be some more bulging, and certainly the annulus and Z-joints continue to bear more load compared to the previous. Now, depending upon who the person is, they may frankly herniate, which is what we see in the next slide. You have frank herniation, you got a grade 4. So now what happens is the MMPs finally bust through the outermost annular layer. And it's the MMPs that do it. You may have a loading event, but it's the MMPs that set the stage for the nuclear material to move out. This looks like a protrusion. They've got discogenic pain. Do they have nerve root pain? They likely do. Again, none of this is 100%. And at this point in time, if the patient did have nerve root pain, they would have inflamed axons in the nerve root that were spontaneously firing, and they would have discogenic pain. So this is where it starts to get really, really, unfortunately, nasty for the patient. And hopefully it stops here, because at any point in time, this can kind of turn around. So as practitioners, you think, all right, well, if there are no changes in neurology, there's no progressive deficits or anything, we can manage the patient. It gets a bit more difficult and dicey, and people get scared when they see more massive herniations and sequestrations and extrusions like we're going to see in grade 5. So grade 5 shows us a sequestration. We got little fragments coming off of the herniated material. Looks like it's occupying more of the space. Is there a compressive scenario there? Potentially. It really doesn't make any difference if there's compression or not. That has no bearing on what you do. So what we as DCs, PTs do it too. The deal is, if there is progressive neurologic deficit, you got to move them towards surgery. If there's no progressive neurologic deficit, then what we do is everything we can to modulate their pain, and that means calm down the inflammatory reaction, because now you have this herniated material that's kind of exposed, and you get a much more robust immune response. And when this herniated material hits the dura, you let up a rather robust inflammatory response. And if it gets through and lights up the nerve roots, spinal nerve axons, then you have this spontaneous pain experience taking place mid-axon. And so now the patient is majorly suffering, freaked out. Sorry? So the patient potentially freaked out. They go online, they look at that, they're going to think, oh my God, I'm going to have surgery, my back cut open, and all these different things. So patients who have a herniation like this, they may present with moderate pain, well, mild, moderate, or severe to the point of, gut-wrenching pain. So what you need to do as a DC is think, all right, well, if there's not neurologic deficits, then I'm going to do what I would do with every other patient. And that's pretty much 4 steps, basically. So what you're going to do is you're going to, whatever level of manual care you can do, maybe nothing initially, maybe just use modalities, try to modulate their pain with posture and rehabilitation, and then try to modulate their pain with diet. Now, my suggestion to make your life really easy is to use the anti-inflammatory diet and use the Nutritional Foundation booklet that Bob and Brian can get you directly from Anabolic, and then load them with a supplement that will help to calm down inflammation from 3 angles. So when I was looking at reformulating the Nutra-Disc, which was a product that Anabolic had named for years and years, we reformulated it to be really current with at least the available, consistent with the available literature, and that included, as you saw, the bromelain, a lot of bromelain, and the cerezymes, and then the absorbable curcumin. So the idea with regular curcumin is that it tends not to get absorbed through the GI tract very efficiently. It has a wonderful anti-inflammatory effect in the gut, which can have a peripheral effect, but the Mariva phytosome version of curcumin gets absorbed. So the combination of getting anti-inflammatory connective tissue building glucosamine, anti-inflammatory analgesic curcumin, and anti-inflammatory analgesic enzymes as well is very, very important. So when it comes to effectiveness with this, it really boils down to how flamed up the person is, and so some may need just 6 Nutra-Disc a day, some might need 9. I mean, I take 6 just to take them because I do have a synovial cyst, and I take it just as a way to make myself as anti-inflammatory as possible in case something unhealthy and inappropriate happens. So you can see the dosing recommendations that are on the screen. Now, Brian, you want to take over? You wanted to come in now, didn't you? Talk more about this.
Yeah, just feel free to chime in. Obviously one of the primary questions we get when we're out presenting and discussing and training on the product is, well, how much should I give a patient or recommend a patient? The official dosing recommendation from the company is up to 6 per day. In talking with a number of folks, including Dr. Seaman, clinically, I've taken a top-down strategy in regards to my recommendations. Obviously, it always comes back to the doctor, because you are the one working with your patient and monitoring your specific situation. But I have it written as a top-down strategy as far as a starting point. So for your most acute case, 6 per day, which I've experimented with myself, also being a disc patient, is a good place to start in regards to maxing out the company's recommendation and looking for that starting point with your patient that's in a good deal of pain. And then as that starts to subside, you can taper that down to levels of 3 to 2 per day. Obviously, when your patient stabilizes, which could be anywhere from 2 weeks to 2 months, that's your reevaluation point. And then long-term recommendations as far as supplements to add into the diet after the use of Nutra-Disc would be obviously glucosamine, chondroitin, and I have our ProEnz formula listed because it's botanical anti-inflammatory with a lesser proteolytic enzyme load. So this is used, has been used over the years quite effectively on an extended basis. And then as Dr. Seaman mentioned, obviously the additional long-term recommendations would be the anti-inflammatory diet, which we have nicely spelled out in our Nutritional Foundation booklets available to you. Fish oil, vitamin D, and magnesium, basically the primary nutritional supplements that address the major deficiencies in the American diet and all contribute to a more anti-inflammatory diet regime. Dave, did you have anything you wanted to add to that?
So I have taken up to 12 a day just to see what would happen, and when I did injure myself, wasn't a disc injury, but I dosed with 12 a day for a few days just to see what would happen with bowel changes or anything else like that, because I would never want to recommend that someone goes high unless I went high myself. So I'm actually comfortable with 12 a day, assuming that there's no drug interaction scenarios like the biggie, of course, would be warfarin, and taking it maybe with NSAIDs or if they're on a anti-platelet scenario with aspirin. Assuming that there's not a whole lot of drug action there, and you can of course do cross-checking to see if it's okay. I am comfortable with 12 a day, depending, because when it really hurts, the more the merrier when it comes to loading with these guys, and that dose is not too far off. People have used long term for rheumatoid disease, so I would be comfortable going higher, because I don't want people to think that they can only do 6 a day. And I'm not talking from the perspective of being the company now. This is just me saying this, and I take 6 a day, and I'm not even actively inflamed. I'm preparing for my next injury in advance, so that when I do get injured, I'll have a robust anti-inflammatory response when that does happen.
Okay, thanks. The other question we address obviously on a regular basis are pricing guidelines for the patient. So what I've outlined here is the clinic cost, which would be your cost in purchasing from Anabolic Laboratories outside any of the introductory offers or specials. So the 90 capsule bottle at $25.45 and the 180 capsule bottle at $49.59. What I've done is initially introduce the product with some patient pricing, quite frankly on an experimental level myself, so I've got a number of clinics using this patient pricing. So the 90 capsule bottle between $40 and $45, the 180 capsule bottle between $75 and $80. And in arriving at these pricing, the typical markup of products historically has always been 100%. I looked at this as an opportunity for you to provide a very effective nutritional / nutraceutical product that addresses a very serious and specific situation with patients who, quite frankly, are very concerned and typically will go the extra mile when it comes to finances to address the reduction of that pain and getting back to some sort of state of normalcy. So for a patient to, at full load, 6 per day, quote unquote, 180 capsule bottle, which would be a month's supply, $75 to $80. The feedback I'm getting seems to be coming back as a very reasonable price. And that's feedback, and then also when we look at sales of the product, which have been quite good, that also gives us some hard data as far as, yes, we seem to be in the ballpark with this. So your patients that either aren't in as much pain and or do not want to invest in, say, a full month's supply, there's always the 90 capsule bottle, which could go for 2 weeks. Now, if you've got a patient with lower inflammatory response to their situation, then obviously you can work down in regards to how much they would take, and quite frankly, their dollar would just go that much further. But these patient prices, like I said, seem to be in the ballpark of what people are willing and interested in paying. If Bob Rosenberg is still on the line, our Pennsylvania, New Jersey rep, if you have any other comments in regards to this, certainly would like to hear it.
No, I think your strategy is on target. My doctors tend to find that getting above that $40-$45 threshold is difficult within a lot of markets, so they're going with 90 count bottles for the 2 weeks and following up with another 90 count bottle for the next 2 weeks and using it that way.
So some of the patient,
way you can get it done.
So some of the patient education material that's available at no charge. First one would be the patient education card. It's a nice two-sided card. A very brief presentation and overview of what the product is and what it's for. And once again, both Bob and I have been involved in the sales and marketing of these products for over 20 years. And the bottom line is patients like to take information with their products. It's a much more comfortable transaction if they have an explanation other than what's on the bottle. And as you can see on the back side of the card, there's some room for you to make some notes. So I always encourage my clinics to keep these in stock and use them liberally, even if the patient is thinking about or has decided not to take the product. Have them take the card. History shows a lot of times they'll come back in next time with the card after they've had a chance to sit down quietly and look it over and or share it with a friend or somebody else. Another patient education piece we have for you is the waiting room treatment room wall poster. Once again, this is available at no charge. And the third would be the 8 by 5, 8.5 by 11 counter display easel, once again available at no charge. So we've got some nice materials to create some awareness with your patients, put out at some strategic locations. I've always found that the clinics that do this just get a more positive response when bringing up the formula and the option and potential of using it, and or the patient spots it and will inquire it from you. And just as a to kind of wrap things up, this is one of Bob Rosenberg's doctors in Pennsylvania who sent him unsolicited a nice testimonial. It's always nice to have a chiropractor who has used the product successfully with his patients as well as on his, himself. Not that we're happy that he got to this point, but here's a chiro that's had a disc situation, has tried numerous things, and basically has found some real success with Nutra-Disc. So if you wanted to talk further with Dr. Cianci, I'm sure he'd be happy to pass along any other feedback or information on his use of the product. Once again, he's one of Bob's clinics up in Pennsylvania, so you can always go through him if you don't feel comfortable contacting him yourself.
I'm actually on the phone if you guys can hear me.
I'm sorry, what was that?
This is actually Dr. Cianci.
Oh, great. Good. I didn't see your name on the list there. Anything you'd like
called
to
it from
add?
my vehicle. I couldn't. Pardon me?
Anything you'd like to add for us?
You know, I don't know if everybody read the testimonial that I wrote, but I did find, I talked about this, and then I talked to someone else over at Anabolic Labs. That was doing 3 a day, three tablets twice a day, finding it difficult to do the empty stomach. I was doing a real strict empty stomach. Bob talked me into not being quite so strict with that, and it's been fantastic. So basically, I'll take it an hour before a meal, hour to an hour and a half after a meal, and a little bit more consistently doing two capsules several times a day that way, and it's been amazing. I can wake up in the morning, stand up straight out of bed versus being hunched over. I'm waiting for the weather to break so I can start running outside a little bit, and I haven't been able to do that in about a year.
Terrific.
All right, great.
And the reason why you want to try to do it 3 times a day instead of two times a day for anybody who's listening is the half-life of the Meriva, of the bioavailable curcumin, is roughly 240 minutes. So you're looking at about 4 hours half-life, and that versus maybe 10 to 15 minutes half-life of standardized turmeric extract. So this thing stays in circulation a good long time. So you figure if you're doing it 3 times a day, you're really not letting the blood level diminish too much with the bioavailable curcumin. So the 2-3 times a day is probably the way to want to continue doing it.
Thanks, Bob. At this point, we got a few minutes. We got Dr. Seaman on the line. We've got Dr. Sancy. We've got a host of other doctors on the line. I just wanted to open it up for any Q&A that anybody wanted to throw out there. That's a great opportunity to pick Dr. Seaman's mind while we have him.
Yeah, we have a question.
Go for it.
Why does the MMP get turned on in the first place?
So the MMPs are like any other inflammatory mediator. They're you can actually do a blood draw, and you can and cytokines and prostaglandins, growth factors, MMPs, they'll all be measurable. Patients who have metabolic syndrome, they have actually elevated levels of circulating MMPs. So the more flamed up somebody is, the more turned on they are. It's just sort of part of the process. So if you eat an inflammatory diet, live an inflammatory lifestyle, the more MMPs get turned on because they are part of the collection of chemicals that get turned on. So whenever there's any injury, there's always a remodeling scenario. You guys all learned about soft tissue injuries and remodeling. Well, part of the remodeling phase, or I should say, as the acute inflammatory and the repair phase is to remodel the area for healing. But if we do not turn the MMPs off, which they're turned on for a normal process, if they don't get turned off, someone turn down your sound a little bit. If we don't turn the MMPs off, then they go through that progressive degradation process. So they're supposed to turn on. Whenever you have a little injurious event, they're supposed to turn on. And for some people, they'll turn on, and then you go from a grade nothing to a grade 0 to maybe a grade 1, or maybe not even get to a grade 1, and they turn off because the system says turn off. And they're turned off by what are called tissue inhibitors of metalloproteinases, and those tissue inhibitors are activated by anti-inflammatory signaling. So without anti-inflammatory signaling, it tends to progress to herniation. Did that do it for you, whoever asked that question?
I got
That was very helpful. Thank you.
I got a text question. Bob Rosenberg, you broke up a little bit when you were talking about the half-life of Meriva. Could you repeat that real quick?
Oh yes. The Meriva, are you hearing me okay now?
Yeah.
The Meriva has a half-life of 240 minutes. And that compares to standardized turmeric extracts that have a typical half-life of 10 to 15 minutes. So you're looking at a much higher order of magnitude of keeping the curcumin active in the bloodstream. You're looking at 4 hours versus 10 or 15 minutes, which is why you need to take traditional turmeric all day long to keep the blood level going. With this stuff, it stays in circulation a good long time. So if the half-life is 4 hours, figure your total life is about 8 hours, which is why you want to take it 3 times a day just to keep the blood level going. Are we okay on that?
That was good, Bob. There's just one more thing I want to throw in there regarding that metalloproteinase question. If those on the phone those who are still on the phone, if you haven't read that discogenic chemistry of discogenic pain and disc herniation mechanism piece that I put together, Ryan and Bob can get it to you. I think you can get it online as well. Go through that. Use it to fall asleep with at night if you want. I think it'll be very helpful because it describes sort of the side of spinal dysfunction that we really didn't get because we were taught spinal dysfunction from a mechanical perspective, which is true, but then there's also this chemistry side that also needs to be understood. And so there's a step-by-step picture sequencing that takes place to show the chemistry. The metalloproteinases are described in more detail. The individuals who are more likely to herniate are described in more detail. Even just your diabetic patients, your patients with metabolic syndrome, they are more likely to herniate because they're more inflamed. So type 2 diabetics have much more frequent herniations than your average person after you get past that young age of where herniation is common. So and all your other musculoskeletal pains too are driven by metabolic syndrome. And that's kind of all described, I think, fairly well in that chemistry piece that I showed in my first slide. I'm muting now.
Yeah, to follow that up, like Dave mentioned, if you would like a copy of the paper he was reviewing, that is available via download from the anaboliclabs.com website, and we can also always send you a hard copy as well. Do we have any other questions?
Yeah, I have a question. Can someone address how this product can help other joints as well?
Dave, you want to handle that?
Sure. Yeah. It's when you think about patients and how their brains work, they're very fragile, and their disc is bothered, and they want something for their disc. So Nutra-Disc is a really good name in that context. But I take it every day, independent of disc herniation, and my main problem is a synovial cyst that I'm hoping doesn't light up again. So every single joint is, except for the nucleus itself, all joints have very, very similar microstructure, anatomy, and chemistry. So it can be used for strained sprains, ankle sprains. It can be used after a SI joint lights up. So it can be used for any tissue that's similar to the disc, which is all your musculoskeletal tissues. The name is just, it speaks to the patients with discopathy, but it can be used for Facet syndrome, Discogenic syndrome, sprained ankles, tendinopathies, etc.
Thank you.
And if I can just piggyback on top of that for a second, this is Bob. I do have doctors that are using this for more maintenance type situations for themselves, where they're just weekend warriors. They have patients that overuse their joints, whether it's running or biking or hiking or shoveling snow or whatever it happens to be. And some of your athletes and others just don't want to reach for separate bottles of things, and here you're getting your glucosamine chondroitin combined with your botanical anti-inflammatory, along with your enzyme anti-inflammatory. And it's just a convenient way to get all of those things in one bottle at a maintenance dose or a low dose of 2 or 3 a day versus the acute discogenic patient.
Yeah, I just want to make a comment to follow that up as well. In initially working with some clinics who really took a liking to the product and put it in play aggressively, a primary patient feature which translates to the doctor as well is the fact that, as Bob noted, you got 3 primary components wrapped up into one formula. Anytime a patient, especially a disc patient, has less to concentrate on, your compliance level goes up. So the patients have just been very happy with the fact that they just need to focus in on this product. It allows you to help them focus a little better on the anti-inflammatory diet, and then obviously your treatment recommendations and any rehab exercise programs that you want to have them do as well. So we're kind of taking historically what's been a number of different products that they would have to keep track of to address their situation down to one, and that just opens up more headspace for them to concentrate on the other things that are very important to their rehabilitation and stabilization as well.
So we have another question over here. So on our original implementation of it in our office, we gave it to some back patients and a couple knee patients, and our knee patients are actually doing really well on it. And one of those knee patients tonight asked me about her friend who has, quote, bone on bone, and asked if it would help regrow the cartilage in the area, and I just wanted your opinion on that.
Dave, why don't you take that one?
Yeah, sure. So it's hard to say. The only way to look at any of these things is to try it and see. And some patients who are bone on bone need not be in pain. It's a weird thing, joint pain. A DC who was getting ready for hip replacement surgery told me that when he first tried the various COX-2 inhibitors, Bextra didn't work for him, but Vioxx worked for him, Bextra didn't. He goes, I really don't want to have hip surgery, and I'd like to not, get screwed up with the NSAIDs. So, you think this anti-inflammatory nutrition and all these supplements will help me? I said, well, it's not going to hurt you, that's for sure. And if it helps you, as they say down in Aussie land and in New Zealand, good on you if it helps you. So if she's bone on bone, getting anti-inflammatory and healthy, if she has to have anything more aggressive done, will make her a healthier person to deal more effectively if she goes in for a planned trauma called surgery. So either she'll be more healthy for surgery, or she might get lucky and feel better. So it's worth doing just to see. People like that, I would urge them very strongly to be anti-inflammatory with their diet, find out what their vitamin D levels are, get them in the high normal range, be as anti-inflammatory as possible. Magnesium is extremely important for joint and bone health. So really that person needs kind of the whole program, and hopefully she'll get lucky.
Okay, I've got another.
That's kind of what I said to her. So thank you for calling.
I've got another question that came in. Any problems with taking it for long periods of a time at 6-tab dose for chronic disc patients?
Well, I take 3 in the morning, 3 at night, every day for I don't even know how long now. So, and the reason why I'm doing that is because I want to be anti-inflammatory, and I know that the chance for any side effect is so remote that it's really not an issue. So I can't say specifically for that person. I can say specifically for me and other people who I've encountered, it's not a problem. And the formulation itself is not problematic. Does that mean it's safe for everybody? We can't say that specifically.
All right, just just to add in there, one of the reasons I started this program or this thing was for my dog who has a disc, and she takes anywhere from, and she only weighs 30 pounds, 3 to 4 a day, and she's been taking it for 6 to 8 months, and is doing better. Did you catch that?
Well, it's always great.
Excellent testimonial.
Yeah.
That's a great testimonial. A 30-pound pooch can handle 4 a day. I think a 110, 120, 150, 200-pound humanoid can handle, the load that we're talking about otherwise. So thank you very much for that.
No, it was a 30, not 3.
No, yeah, a 30 pound, right? 30 pound.
Yeah.
30-pound pooch. Yeah.
And
So
it has stopped the progression of her disc degeneration. She hasn't gotten any worse in the past 6 months. So it's
That's
been
awesome.
This is one of the reasons we ordered this, because I was looking for something for her disc, and now then we switched it over to our patients.
Well, you can try it on yourself first to make sure you can try it on your dog, and then do it to your patient. That's a smart move.
It works. I use it now too. But that's the reason we started it, was for her, and she's done very well on it, and I'm really pleased that that her regression of her disc and her symptoms have stopped in the past 6 to 8 months. It's been very, very good, and she takes anywhere from 3 to 4 a day.
Okay, do we have any other questions?
One more question.
Okay.
Someone mentioned high doses and warfarin, or I'm sorry, Coumadin. What's considered a high dose? I mean, if the patient is on Coumadin for whatever reason, how much can they take?
Yeah, when it comes to any patients on your blood thinners, so you don't want to give them anything like CoQ10 or enzymes, because anything that is going to further so-called thin the blood is not really what you want for a Coumadin patient. So I wouldn't use really any supplements on a patient who is on Coumadin unless I did it in conjunction with the MD, knowing that they're going to be taking something that might increase their INR a little bit. Other than that, though, when it comes to drug interactions, the main thing with drug interactions, I mean, this is general, it's not specific, so you can't hold me to it even though it's on this tape, is that the idea, like I said, for certain medications, you shouldn't take magnesium with them. You can take magnesium, but just not the medication. So my approach would be, if the patient's taking a couple medications, then you wouldn't want to take any supplements at the same time you're taking your medications. And that's the general way to look at it. My suggestion, and what I did with patients, was I would run their supplements in conjunction with their drugs through eMedFX. And you can talk to Brian or Bob about that, but it's emedfx.com. And I would look at the drugs and the supplements, and that way I would know if there are interactions. 99% of the time, there was not interactions. There were not. So you're pretty safe with these natural products.
Fantastic. Thank you.
You bet.
Okay, we're at the 60-minute mark here. I want to thank everybody for tuning in and listening. If you have any additional questions, you can always address those directly to either myself or Bob Rosenberg. And if we can't answer it, or you'd like an opinion from Dr. Seaman, we can always pass those along to him and get your response back as soon as possible. So once again, thanks for joining us, and look for our next webinar probably in the next 60 to 90 days. And love to hear any feedback from you on the program, and anything that you'd like us to try to address in regards to nutrition, nutritional supplementation, and your practice. Once again, this is Brian Miller with Anabolic Labs. speaking for Bob Rosenberg and Dr. Seaman, thanks again, and we will be with you next time.
Thank you.